Step 3, which is prioritizing hypotheses. Again, with the prioritization, this is always, always so important. And for step 3, we need to figure out, where do I start? And the NCLEX might ask you this as, what is the client most likely experiencing? Or are they at highest risk for? Or maybe they'll just say, what do you need to do first? And I like to think of this like this. If I can only do one thing for my patient and then walk away and my shift is over, what is that one thing going to be? If I'm going to do just one thing and nothing else, what will solve this problem the most directly and quickly? All right, so let's consider that. We're being asked, the client is at highest risk for developing blank and blank, and that's either going to be respiratory failure, acute kidney injury, sepsis, or pulmonary embolism. Here, the client is at risk for all of these things, right? But we need to figure out what they're at highest risk for from heart failure. So are they at high risk for respiratory failure? And I think you guys know this one, right? We've been talking about this as our priority problem. We've got respiratory insufficiency, we've got crackles from heart failure, and he's already on his way. We've got a low pulse ox, we've got tachypnea, so I'm definitely worried about respiratory failure with him. But what's our next one? And a couple of you have said AKI, drop in some other guesses. Okay, so let's think about each of these. So is somebody at risk for acute kidney injury from heart failure? And you guys have guessed this. Right, because remember, if the heart can't pump blood forward well enough, not only is it backing up into the lungs, risking respiratory failure, but it's not getting to the organs. And that is going to put you at risk for any kind of organ damage. But the kidneys are especially sensitive to this because they get 25% of your cardiac output. So that means for every liter of blood that your heart pumps, 250 mils of it is destined for the kidneys. They depend on a lot of blood flow. So the second that your cardiac output drops, your kidneys start to suffer from that reduced perfusion. So I am worried about this, but I'm not sure it's the highest risk yet before looking at these other two. So let's think about this. So sepsis. Who is at risk for sepsis? Patients who have what kind of problem? And some of you might say, well, anybody in the hospital is at risk for sepsis. And because anyone in the hospital is at risk for infection, that is true. But we typically worry about somebody developing sepsis if they already have an infection. And so remember, we decided we don't have any yellow-green sputum, we don't have any fever, we don't have any elevated white blood cell count. So this is a lot lower of a risk unless he already has an infection present. So I don't think it's this guy. And then pulmonary embolism. So if he has prolonged immobility, if we hospitalize him and fail to give him those Lovenox shots or put SCDs on him, then he could develop a DVT and maybe a PE. But we don't really have signs of a DVT. We've got bilateral lower extremity edema. If you had edema on just one leg, that might be more concerning for a DVT, right? But if he's got it in both legs, as well as all of these other fluid overload related findings like our S3 and our crackles, I might be more suspicious for that. But because he has all of these, that is, I agree with you guys who guessed this, what my other one is, acute kidney injury. So respiratory failure because blood backs up from the heart, acute kidney injury because it's not moving forward from the heart. And we're correct.